Hi friends, I am Dr. Sharma and I will be discussing in this talk the diagnosis of a urethral injury. The objective of this talk is to describe the radiological investigation which are needed to diagnose a urethral injury and to describe the classification of urethral injury. The main investigation which is used to diagnose a urethral injury is an ascending urethrogram, which is correctly termed as a retrograde urethrogram. This was first described by Cunningham in 1910. Flox refined the procedure in 1933, but Macria was the first to use it in patients of urethral trauma in 1940. There are certain principles which need to be followed when one does an RGU, that is a retrograde urethrogram, and I would term these principles as the CAP principles. Counseling and comfort of the patient is of paramount importance. The patient has undergone a trauma. Very often it could be associated with other major injuries. He is in a lot of pain and discomfort. Spending a few seconds to explain the procedure to the patient helps in allaying his fears and getting his comfort to a very high level so that he can cooperate very well during the procedure. The second principle is asepsis. RGO is an invasive procedure where a contrast is instilled in the urethra by use of a device which could be a Foley adapter, a small Foley catheter, or an infant feeding tube. A contrast is injected in an area which is likely to be traumatized, and hence it's of great importance on part of the person who is doing the procedure that all aseptic precautions are maintained so that any infection is not introduced. Even if all asepsis is maintained, it is imperative that an antibiotic cover is given so that whatever little infection might have inadvertently been introduced is taken care by use of antibiotics. The position of the patient, it's usually an oblique position which is given. Now why this is important is these patients who have undergone trauma may have a pelvic fracture, and hence positioning of the patient may be very difficult. Now there are two things which one need to remember. One, always do a KUB before you do an RGU so that if there is any pelvic fracture that can be picked up, and based on whatever are the findings of that particular KUB, position the patient very gently without causing discomfort to the patient. Now along with an RGU, an ultrasound is also often done so that the status of the bladder is known, and if one knows that the bladder is reasonably full, say about 400 to 500 ml of urine is seen on ultrasound, you can be bit confident that yes, there is no chance of a bladder injury. Now why this is important? Because 10% of the times a urethral and a bladder injury can coexist. Now how do we classify a urethral injury? McAninch and Armenkas have given a very simple classification of urethral trauma. They have divided it into contusions, incomplete rupture, and a complete rupture. Contusion is when there is trauma to the urethra with incomplete rupture of part of the urethra but no disruption of the urethral epithelium, which means that there is injury to the spongiosa but the urethral epithelium is not disrupted. Incomplete rupture is when there is rupture of part of the circumference of the urethra. There is damage to the urethral epithelium, but there is maintenance of the urethral continuity at places, which means that though the urethral epithelium and spongiosa are damaged at places, at other areas they are maintained in continuity. The third is a complete rupture, where there is a complete disruption of the circumference of the urethra. The two ends of the urethra have got separated. There is no urethral continuity either in the form of spongiosa or epithelium between the two ends, and usually there is blood which is present between these two ends, and this is important because this blood is a hematoma which will ultimately heal by fibrosis and separate the two ends of the urethra. and this has implications in the management of the patient. The classification based on RGU is the contusion is diagnosed if the clinical features are suggestive of a urethral injury, that is, there is blood at meatus, there is trauma to the perineum, there is perineal hematoma, but an ascending urethrogram or a retrograde urethrogram is totally normal. In these patients, you can safely put a catheter. Incomplete rupture is when a retrograde urethrogram is showing extravasation of the contrast, but there is maintenance of the urethral continuity, which is shown by the fact that some contrast is entering into the bladder. And the third is a complete rupture, where an ascending urethrogram or a retrograde urethrogram shows extravasation, total extravasation, with no filling of the proximal urethra or bladder. Now friends, we need to remember that in an anterior urethral injury, incomplete rupture is more common, and in a posterior urethral injury, complete rupture is more common. Now there have been three classifications which have been proposed. In 1977, Colapinto and McCallum proposed their classification, which has been subsequently modified by Goldman in 1997, and then in 2005, European Association put forth their own classification. The basic aim of these classifications have been to classify these injuries as per their radiological and clinical relevance. Unfortunately, experts like Anthony Mundy believe that none of these classifications have been able to completely solve this dilemma. Now, why? There are certain problems with a RGU. When you do an RGU in a patient of urethral injury, it is very accurate as far as the site of injury is concerned. The diagnosis is quite certain that this is the area where the injury has occurred. But when we see the type of injury, RGU is not very accurate. What I mean by this is, a contusion is very easy to diagnose. The urethra is looking perfectly normal. The problem comes when you have to diagnose an incomplete rupture and a complete rupture. Now sometimes what happens is, when a contrast is injected, there would be extravasation and no contrast would enter into the proximal urethra or the bladder, and the diagnosis would be a complete rupture. But many of these patients, if they undergo a second RGU after say 2 to 3 days, that complete injury which was seen initially would now be diagnosed as an incomplete injury on an RGU. This is so because initially, when there is trauma, the contrast follows the principles of following the path of least resistance, and so no contrast is entering into the proximal urethra, especially if there is some spasm of the sphincter which is present. Later on, when the RGU is done after say 2 to 3 days, a so-called complete injury might be then seen as an incomplete injury, and this is why none of these classifications are very popular. The easiest way to classify an injury would be as a contusion, incomplete rupture and a complete rupture. Now why this is important is we will discuss in my next talk on the emergency management of a urethral trauma. Thank you. For further such videos, please log on to edmedonline.com.